this? It's on schizophrenia. So I am Professor Madhubhashini Dayabandar, if you don't know me, from the Department of Psychiatry. And, when we talk about schizophrenia, I think the typical picture which comes into your mind might be of, a very severe psychiatric illness, isn't it? Yes, it is. When we talk about major psychiatric illnesses, we talk about three illnesses. One is schizophrenia, the second one is bipolar affective disorder, and the other is depression. It is not to say that the other mental illnesses cause a lot of dysfunction and lots of unhappiness and disorganization and poor functional level, but these illnesses affect the person, the almost all the aspects of a person's functioning. Mood symptoms, cognitive function, social functioning, occupational functioning. Therefore, it's very important that these illnesses are properly treated. That's why we call them major psychiatric illnesses. On the other hand, a diagnosis of such an illness usually in the diagnostic criteria trumps over the others. For example, the person might be having some obsessional symptoms. But always the diagnosis of schizophrenia comes first. Of course, there might be a comorbid OCD going on at the same time. So, where diagnosis is concerned, also these illnesses take more priority than other comorbidities. Okay, let's have a look at three patient scenarios. All three patients are actually patients whom I have seen quite recently. This patient is actually currently in the ward, and the next two patients were also there in the ward recently. So let's read through the scenarios. I will take you through, and then from time to time when I'm discussing symptoms and treatment, I will be referring to these scenarios so you can relate them to practical clinical aspects. The first patient is a 19-year-old girl currently doing her A-levels. For the last 2 years, she has been socially withdrawn, isolated, tends to stay inside the room.
Excuse me, madam.
And yes?
Madam, my slides are not moving.
Ayo. First one, dakkada? Palaveni එක dakkada?
Madam, can you make it full screen?
Yeah, full screen කරලා දෙන්නේ මාව. Okay, let's share again.
Okay, madam.
කොමින්ද ආපහු share කරන්න. සමහරවිට desktop එක share කරපුවාම it's properly shared. So I'll see if, can you see?
Yes, madam, now we can see.
Okay, හරි. මේ ඊළඟ slide එකට ගියාද දැන්?
Yes, madam.
හරි. Okay, at any time if the slides are not progressing, please alert me.
Okay, madam.
Right. So the first patient, 19-year-old girl currently doing A-levels. For the last 2 years, noted by the parents to be very withdrawn, stays inside the room, doesn't interact much with her parents. Has done O-level, quite satisfactorily, but after that, she does not pay much attention to her studies. And, even though there is not a lot of disorganization, some irritability towards the parent had been noted, but she has not been overly aggressive or violent. But, when on assessment, she expresses this belief that her father is somehow causing sexual sensations in her, and this is very distressing to her. Therefore, she has withdrawn into the room and does not come out to be seen by her father. And on further assessment, she came out also with the belief that her friends are actually interfering with her thoughts, and that friends are actually putting in thoughts into her head, and some are actually taking out her own thoughts. And because of these, symptoms, she had been quite sad. And low mood had actually been the only symptom which had been noted by the parents in the beginning. And funny enough, when she had gone to for psychiatric treatment, initially around a few months after the onset of her symptoms, she was diagnosed as being depressed, and she didn't receive proper antipsychotic therapy. I think the patient was also a little bit guarded, and she did not reveal some of her symptoms during the first assessment. Okay, so she was diagnosed with schizophrenia eventually. Of course, there were a lot of other symptoms and other, supportive evidence for her diagnosis, but this was the main presentation to our unit. Okay, then the next patient was a 24-year-old male, young person. He had been using cannabis regularly for the last 4 years duration. So almost daily cannabis use. He buys around 500 rupees worth of cannabis, shares occasionally with friends, but most of the time he uses it himself. He was noted to be acutely ill. So not over 2 years duration, very gradual illness like the previous, the 19-year-old teenager, but acutely ill over a few weeks duration, very disorganized, became very, restless and aggressive, suspicious, and believed that the neighbor is controlling his actions. Actually the neighbor was, by some mechanism was controlling some of the restlessness that he was feeling, and was actually making him walk. He also heard the voices of 2 or 3 neighbors talking among themselves, plotting to harm him. And this was very distressing to him. And, of course, there were persecutory themes also going on, because that the neighbors intended to kill him. He also had poor sleep and was very irritable towards family members and the neighbors, who he believed to be having persecutory intentions. Okay, so this patient eventually presented to us around 1 to 1.5 months later after onset of symptoms, and was again diagnosed with schizophrenia. Must say though that the first at the first presentation, we did consider a substance-induced psychosis. So we will actually discuss this differential diagnosis as we go along. The third patient, a 27-year-old young male with mental retardation, had been on treatment previously also for a psychotic illness. We couldn't find the diagnosis, and therefore we were unable to find out what medications he was on. Presented with 3 to 4 days ago, he had been having poor sleep and was noted to be muttering to himself. This was the only change that the parents noted. Then, of course, he became stuporous. So in mental state examination and in psychopathology, I think Dr. Anuprabha might have talked about patients who present in stupor. Stupor is where the patient is inactive, does not get up from the bed, but appears to be alert. So the patient will actually appear to be listening to sounds, appear to be, following what is going on around with eyes open. So the patient is not unconscious as such. But if you calculate the GCS, it's lower, because the patient is not actually talking to you and is not actively responding to you. So patient became stuporous and was actually maintaining some abnormal postures. So he was extending his neck at different times, keeping his hand up in different postures while lying in the bed. And he absolutely didn't, the parents could not actually feed him or give him any fluids. And he actually presented to us in a very physically compromised state, because he had not taken any meals or fluids for 2 to 3 days duration. Now, all 3 patients diagnosed with schizophrenia eventually. It was a process, but you can see how different the 3 presentations were. One with postural abnormalities, posturing and abnormal behavior more than anything else. The other person with very acute sort of illness, and the other person with a long-standing illness with a lot of social withdrawal and some mood symptoms. So what we need to understand is that schizophrenia is an illness which presents in different ways. It affects different domains of function. It affects different domains of symptoms. This is what I want to illustrate with the 3 patient scenarios. Okay. It was not long ago that Eugen Bleuler, who was a German psychiatrist, or German or Swiss, I think, named schizophrenia. And if you take the word, schizo means split, phrenia, mind. So it means split mind. This nicely reflects the psychopathology which occurs in schizophrenia. So there is some dissociation or some loosening of the links in your thought processes, which often presents with different symptoms such as thought disorder or with delusions and hallucinations. So it's interesting to note that around maybe a few decades later, his son Manfred Bleuler was the first person who described the prognosis of schizophrenia. Prognosis means the outcome, what happens to these people, what can we expect from the illness, and at that time, that antipsychotics had not been developed. So chlorpromazine came in 1950s, mid 1950s. So the prognosis of schizophrenia was thought to be very poor, because people did not have medicines to actively treat the illness. And that's why if you look at, the historical context, it was initially named dementia precox by a person named Emil Kraepelin. Kraepelin was the father of the current, classification in psychiatry. He identified that a particular group of patients actually had very poor prognosis. They progressed and they had a lot of dysfunction, and they never recovered fully from their symptoms. So that's why he named it dementia precox, which later became schizophrenia. And then he identified that a certain group of patients actually had episodes only, and interepisodically they were better, they functioned normally, which he actually named manic depressive illness, which later came out to be bipolar affective disorder. Okay, so a little bit about the name of...
In this presentation, I will first take you through epidemiology.
This is, I'm very sorry. This, I took this slide from one of my previous presentations. So that's why. So anyway, these are the things that I want to discuss in this lecture. So I'll take you through some epidemiology and etiology. We'll discuss symptoms and signs in detail. I thought I will take a lot of time for that. And we'll discuss the diagnostic criteria and differential diagnosis, and very briefly treatment, because you still have not got the lectures on antipsychotics. Okay. Right. The epidemiology.
Talking about epidemiology.
Oh, I'm going to stop sharing the slides for a moment, and I'll actually delete the voice cuts and get back to you. Chandu, can you see my screen again?
Can see.
Just 1 minute. Can you see your?
Yes, madam. We can see.
Okay, right. Thank you. So the incidence of schizophrenia is 1 in 1,000. But if you take the prevalence, it's 4 in 1,000. It's because it's a long-standing illness, and therefore the prevalence is higher than the incidence. And lifetime risk is 1%. Can you see that is a rather high, isn't it? Which means 1 in 100 people have a risk of getting schizophrenia. So this is, an unfortunate situation. But in my batch in medical school, there were almost, I think, out of the 280 people, there were like 3 or 4 people who actually eventually were diagnosed with schizophrenia. And it was a very unhappy and a sad thing to happen. So you can see it affects anybody of any social strata, and from any socioeconomic background, and it has to be really identified very early and managed properly. Now, onset is at 2 peaks. There is one peak around 20 years. The other peak epidemiologically is around 33 years. This is mainly because there is a tendency for males to have an early onset and for females to have a later onset in schizophrenia. Not that, they are not that females don't have the illness starting early. So you can remember that 19-year-old girl, her onset had been around 17 years of age, which is, which indicates that the prognosis should be a rather poor in this patient, because the onset was early and particularly in a female. Okay. If you take the male to female ratio, it's around 1.4 to 1, which means that more males are affected by the illness than females, and therefore, there is a slight higher prevalence in the males. But if you take older age groups, then of course we find that the male. Now, the prognosis of schizophrenia is further affected by the fact that we have not found one causal factor for this illness. It is multifactorial. Multifactorial means genetic factors, environmental factors, social factors, all these factors come into play in causation of schizophrenia. Even though the ultimate pathology might be a neurochemical imbalance in the brain, lots of factors come into play in causation of the illness. If you look at genetic factors, then the heritability of schizophrenia is around 80%. What we mean by heritability is the variance in the population of schizophrenia attributable to genetic factors is around 80%. So, you can't say that 80%, it is caused 80% due to genetic factors. The variance is attributable to 80%. So this is now you guys are after, I think, community medicine research, no? So you can identify that what it really means. Even if you take monozygotic twins, the risk of schizophrenia in the other twin is around 48%. So this is to say that even if your identical twin is diagnosed with schizophrenia, still the risk of the other person getting the illness is less than 50%. But of course, in first degree relatives, if you have a first degree relative with schizophrenia, then the risk is higher. So if you have a parent with schizophrenia, the risk is higher than if your aunt or uncle is having schizophrenia. The risk to your children is higher if a parent has schizophrenia. The risk to you is higher if you have a sibling with schizophrenia. Okay. Then lots of environmental factors have been consistently identified to be associated with higher risk. One is maternal malnutrition. So during the time, during intrauterine period, if the mother has had malnutrition, and some of the factors which are identified, but there is no causality identified, have been vitamin D. So that might be one causal factor, one risk factor for schizophrenia. Then winter birth, children born during winter time, again have a higher risk of developing schizophrenia in temperate climates. This, of course, they say might be due to the fact that maternal influenza during the intrauterine period. If the fetus is exposed to influenza in the infection in the mother, then again the risk is increased. I think I have not put it down here. And during winter, flu is there is a higher risk of you catching the flu. And obstetric complications. Increased paternal age, those are all risk factors identified as causing a higher risk for schizophrenia. Psychosocial factors are very interesting. Migration, people who migrate from one country to the other have a higher risk of schizophrenia. Now, this is a funny finding, because we wonder whether what is this due to? Is it because people who migrate might be unhappy in their environment? Is that why they are migrating? And if they are unhappy, is it because they have a tendency to develop psychiatric illnesses? We don't know. But in countries like UK and USA, there are lots of research that the migrant population, be South Asian or Asian or Caribbean, those are the populations in which they have carried out these studies, they have a higher risk of schizophrenia. Then in psychiatry, we often talk of life events. When you had the lecture on depression, maybe you might have heard about how various life events can precipitate a depressive disorder. Same for schizophrenia. But in psychiatry, as a general rule, we must identify that life events are very non-specific. So, losing your loved one, bereavement, can actually cause schizophrenia or depression or even a manic episode in bipolar affective disorder. Therefore, the association is non-specific. But definitely, before onset of a psychiatric illness, there is a higher incidence of life events in the preceding weeks or months. So, it's important to talk about life events, but those are non-specific. Right. So up to now, are there any questions? I would be happy to answer any questions, because I'm going to take this really slow. If you have any questions, please, you can ask me. You can stop me and ask me, or you can actually send me on chat. You can send me as a personal message, or you can send a message which everyone else can see. I'll talk. If you have any questions, please do send, because I will be checking the chat as I go along. Right. Now, there is a lot of how about legalizing cannabis in Sri Lanka. I don't know if it will, with this, socio-economic crisis, what will happen to all that argument. But of course, that cannabis is a way revenue and they were promoting cannabis. Now, in certain countries, cannabis is legal. So countries like Holland. There was a tendency to discuss about cannabis also as heavy as a way of relaxation, and various justifications were brought forward. But we clearly know that cannabis increases the risk of psychosis. Cannabis has a very strong association with schizophrenia. It increases the risk of schizophrenia 2.5 times in a predisposed person. And of course, if if there is a predisposed person, it causes an earlier onset of psychosis. So let's say that without any other precipitating factors, the person would have developed psychosis around 20 years of age, and we know that it actually hastens the onset of psychosis, so that the person might actually develop psychosis around 17 or 18 years of age. You remember the third patient that we were talking about, second patient that we were talking about, he had a very strong history of cannabis use, and actually he was diagnosed as being cannabis dependent. So in this person, I think probably the cannabis would have actually speeded up the process, and maybe if he did not smoke cannabis, there might even have been the possibility that the genetic factors might have been kept at bay and he might not have developed schizophrenia. Because you know that even if it is a highly genetic illness, it can sometimes not manifest at all. Okay. Right. So how do all these etiological factors come into play and cause the illness? So we know all these factors cause some kind of pathological change in the brain, and the eventual pathway is that there is increased dopamine stimulation in the mesolimbic pathway in your brain. So mesolimbic dopamine pathway is from your midbrain to the limbic system. Now there are various dopamine pathways in the brain. Mesolimbic is one, which is actually responsible for the psychotic symptoms that you will get in schizophrenia. So if you are looking at my screen, then my cursor is at the mesolimbic pathway. There is the mesocortical pathway, where the synapses are in the cortex of the brain, especially the dorsolateral prefrontal cortex. Dorsolateral prefrontal cortex. Okay, so you can identify which part of the frontal lobe it is, right? And then there is something called nigrostriatal dopamine pathway, originating from the substantia nigra and going into the striatum, where the basal ganglia are. That, of course, is affected by the medications that we are giving. In the antipsychotics lecture, you will hear that dopamine in the nigrostriatal pathway is blocked by the antipsychotics that we are giving to block the dopamine hyperstimulation in the mesolimbic dopamine pathway. So that's a side effect caused by the antipsychotics. And of course, the tuberoinfundibular dopamine pathway, where the prolactin secretion is also affected by the dopamine and serotonin balance when we give antipsychotics. All these things will be discussed in the antipsychotic lecture, but I think it would be useful for you to identify the different dopamine pathways. We have 4 to name that you should know: the nigrostriatal pathway, the mesolimbic pathway, the mesocortical pathway, and the tuberoinfundibular pathway. 2 pathways are responsible for symptoms. 2 pathways are responsible for the side effects. The ones responsible for the symptoms are the mesolimbic pathway and the mesocortical pathway. The mesocortical pathway is responsible for the cognitive symptoms in schizophrenia, and the tuberoinfundibular and the nigrostriatal pathway are responsible for the side effects that that are caused when we give antipsychotics. Okay. So what are the symptom domains in schizophrenia? So we discussed about the basic concept of schizophrenia. We discussed about epidemiology. We discussed about the etiology, and according to the etiology, what is this theory of dopamine hyperstimulation in the brain, and then of course what are the symptom domains. So the basic theory is that there is hyperstimulation of dopamine receptors in the mesolimbic pathway. Therefore, psychotic symptoms are caused, and these symptoms are expressed through delusions, hallucinations, and various other symptom domains. So when we talk about schizophrenia, I told you that it's a major illness and it affects all the aspects of your functioning. When we talk about symptoms, we talk about 4 symptom domains: positive symptoms, negative symptoms, cognitive symptoms, and mood symptoms. I will go through each symptom domain separately, but you have to understand that a person is not made up of symptom domains. A person is a person who functions and adapts to the social environment around himself, him or herself. Therefore, all these symptoms, what they do is they affect the person's social, cultural, social adaptation, the person's ability to be employed, and the person to be functioning as an independent individual in the living environment. So that's how all these symptoms affect the person's functional life. Okay. When we talk about positive symptoms, these are the symptoms that you are very familiar with in your day-to-day life. When we talk about somebody with mental illness, actually people most often refer to these positive symptoms. They talk about hearing voices, they talk about people being disorganized, that the behavior is changing, muttering to themselves about being suspicious and harboring beliefs which are not understandable by others. These are the positive symptoms. But in psychiatry, we talk about 3 groups of positive symptoms. One is thought disorder, the other one are delusions and hallucinations. So if somebody asks you what are positive symptoms, you say positive symptoms are characterized by features which affect your thinking, thought disorder, and abnormal beliefs and abnormal perceptions. So let's go through the thought disorder symptoms. So here we are talking about one group of positive symptoms which are thought disorder. So what do you mean by thought disorder? Thought disorder is where the thoughts do not have logical connection between them. So there are no logical links, meaningful connections between your thoughts. When you cannot identify these links, we say that a person is having thought disorder. How do we identify that a person is having thought disorder? We identify when the person is speaking. A person's thoughts are expressed via speech. So if the person doesn't make any sense when they are talking, you can say that the person is having thought disorder. This we call formal thought disorder. So that's the word that we use when a person, when the person is speaking, you cannot identify any logical, meaningful connections between thoughts. We say that the person is having formal thought disorder. So I'm just explaining to you the simple terms. Please look up the definitions in the Short Oxford Textbook of Psychiatry for you to correctly define the term. When we say that a person is having thought disorder, we say the person has loosening of associations. Loosening of associations කියන්නේ links loosen වෙලා. ඒ කියන්නේ that the links are not identified clearly. It seems as if there are, the links are very poor. The concepts or the ideas expressed are not really very nicely linked to each other. When the thought disorder is very worse, very bad, then of course, the person might actually present with a word, what we call a word salad. So you can't actually identify any proper sentences or any proper concepts or any proper beliefs being expressed. What you can identify is just a jumble of words, and that we call a word salad. This is in a patient with extreme disorganization and very severe schizophrenia. Then, of course, neologisms. Neologisms is again a form of, it's a feature of thought disorder where a person might actually use words which are usually used for something else in a different context. For example, the person might use the word telecommunication in a different means. So when we say telecommunication, it is usually, we refer to, telecommunication methods, like maybe phones and, telegraphs, things like that. But in this context, maybe the person uses the word telecommunication to actually describe a psychotic phenomenon that is happening to him. For example, one of my patients said that the aliens are actually controlling him via telecommunication. When I asked him what he meant by telecommunication, he said that the aliens have actually, the ship is, orbiting around the earth, and they have actually established an invisible thread of connection between that and his brain. So the word that he used to, express that connection and the way that the aliens were controlling him was telecommunication. So you can take that as a neologism. Or it might be a brand new word. Sometimes you find patients use words which you have never heard before. Actually, neologisms means new words. So they can be old words used in a different context which we can't really understand, and or else they can be brand new words, made up by the person to describe some sort of phenomenon which is happening to him. Okay, so when we are talking about positive symptoms, we said that they are of three different groups. One is thought disorder, the next one was delusions, and the next one was hallucinations. So now we are talking about delusions. In psychopathology, can somebody please tell me, when describing in the lecture regarding psychopathology, did someone discuss the features of a delusion and how to identify a delusion, things like that? Could somebody please tell me if that was discussed with you? Is anybody there?
No, madam, it wasn't discussed, madam.
It was not the.
No, madam.
එතකොට history and mental state examination lecture එකක් තිබුණා නේද?
Yeah, yes, madam. It had only a small part, madam. It was just uploaded, madam. It was not done. It only had a small explanation, madam, not extensive or something.
එතකොට psychopathology වෙනම lecture එකක් තිබුණා නැද්ද ඔයගොල්ලන්ට?
No, madam.
The first one was classification and introduction to psychiatry නේද?
Yes, madam.
Phenomenology. එතකොට phenomenology කියන එකෙත් කරේ නැද්ද?
No, madam. Not like that, madam.
Sorry, then next
then
lecture.
was history taking and that thing.
Right, okay. Now, if I don't have any time, I will probably run out of time to finish this lecture. So I will have, actually, I think it's very important that you have something on psychopathology. So maybe I'll discuss with Janitu and Devanmini and arrange a separate lecture for psychopathology. Okay? Right.
Okay, madam.
So let's talk about delusions. Now, delusions, if you read the short Oxford textbook of psychiatry, there is a definition. And it's important to, learn this definition because it is something that will help you in identifying if a patient actually has delusions or not. On the other hand, it is important because we ask it repeatedly in exams and in, in clinical exams, in written exams. So it's important, this is bread and butter for psychiatry, delusions and hallucinations. A delusion is a abnormal belief. So it's a thought, it's a belief, it's an idea which is not understandable. So it's not understandable by others as, arising from the socio-cultural background or the religious background of the person. It's usually false. I say usually false because sometimes the belief can have some evidence to the otherwise. This is only actually in one particular situation where the partner might be having delusions of infidelity, and the actual partner might actually be having a relationship, but we decide it's a delusion depending on some other criteria. So when we discuss psychopathology, I will further discuss about that. So it's an idea, a thought, or a belief which is not understandable. It is usually false, and it is very strongly held. It's very strongly held, so that even if you give evidence to the otherwise, if you argue with the persons, it's not shakeable. So we usually don't try to argue with a person having a delusion. There's no point, right? So you give you give treatment, and then of course the delusion will weaken. When we talk about positive symptoms in schizophrenia, there are actually, it's in schizophrenia where particular types of delusions occur. We talk about different types of delusions in schizophrenia. Primary delusions. Primary delusions කියන්නේ delusions which occur at the very beginning or onset of schizophrenia, which are characteristic of schizophrenia. So these are actually diagnostic of schizophrenia. Let's go through each and every one. Autochthonous delusions. Autochthonous කියන්නේ, if you look up the meaning of autochthonous, කියන්නේ එකපාරටම ආවා, suddenly, spontaneously happening. Autochthonous, that is the meaning of autochthonous. Look it up on a dictionary, right? The sudden delusional idea කියලා ඉවර වෙලත් පොත්වල කියවනකොට තියෙනවා. If you read the Short Oxford or some other psychopathology book, they might also have the term sudden delusional idea. So out of the blue, suddenly a delusion comes. These are, very difficult to identify in patients who present to us, because they occur within the first few days of the illness, and by the time they come to us, it is weeks or months or even years later, like the 19-year-old girl. So autochthonous delusions are sudden delusional ideas. Out of the blue it happens. There is no background evidence or anything. Suddenly the patient gets the thought, okay, this is what is going to happen. This is going to happen. I am going to be killed like this. Something like that. Delusional perception කියන්නේ, there is a normal percept. A normal perception is what we perceive through our 5 different senses. Our senses are vision, hearing, olfactory, gustatory, and what else? Touch, tactile. Okay. So there is a normal perception which is actually delusionally interpreted by the person. The classic example of delusional perception is, you have a birthmark for many, many years, and when the patient becomes psychotic, the patient actually sees the birthmark and believes that it is it's evidence that the patient is the son of the Queen of England, right? Okay, so that's a delusional perception. There's a normal perception there, right? And but the patient gives it a delusional interpretation. Then delusional mood. Delusional mood කියන්නේ, these patients at the very beginning of the illness, they feel as if something bad is going to happen. One of my patients said that, she was feeling as if something is going to happen, something is wrong, but she couldn't put her finger to it. And then suddenly, of course, she started developing persecutory delusions. So delusional mood is that mood where the patient is feeling something bad is going to happen, and usually in that, the mood of the patient would be perplexed. When you talk about different moods, we talk about perplexed mood. Perplexed mood is where, you can't identify what is happening. You're trying to, make sense of what is happening. And they are very distractible. They are looking around. They're trying to make sense of, and get an idea of what exactly is happening. So the person, if they come in a perplexed mode, might actually be having delusional mood, right? Okay, so the patient believes that something bad is going to happen, but they can't actually pinpoint what is going to happen. Persecutory delusions, the name is, explainable. Persecutory delusions කියන්නේ, delusions which involve the belief that somebody or some agency or some organization is trying to harm you, right? Somebody is having bad intentions towards you. So in the first patient, that young girl that we talked about, she believed that her friends were trying to, they actually were inserting thoughts into her brain and were actually taking out her thoughts also. And therefore, she believed that the friends actually intended harm to her, and also regarding the father, because she believed that the father was causing sexual sensations in her. She believed that the father was actually having very nasty intentions towards her. So therefore, in addition to the thought insertion, thought withdrawal, psychopathology, and delusions of control, she was having persecutory delusions. Then delusions of reference. Delusions of reference කියන්නේ some very innocent event happening around the person. The person believes to be having personal significance. For example, there might be a group of people in front of a shop talking about the weather or something else. But the person, our patient walking in the road, might actually believe that these people are actually talking about the person. Or else maybe in the TV, the news reader might actually say there is about the weather forecast or something else, and the person believes it's a message sent to the person to give a warning that the person might be harmed. So something which is absolutely not related to this person, but the person actually puts some personal significance into that and believes it's a message to the person or is related to the person. Okay. Delusions of control. Now, delusions of control, you must actually read a little bit more about, because these are the ones which are, these are the psychopathologies which are very relevant to you in clinical practice. Delusions of control occur when a person believes that their thoughts, emotions, or actions, motor actions are actually being controlled by an outside person. So they usually give an explanation. For example, can you remember the patient I said that who was using the word telecommunication as a neologism? So he believed that aliens, through those lines, invisible threads, were actually making him work like a puppet, and was actually, having control over his motor actions. So control can be about your thoughts. They can control your thoughts. They can control your emotions. So the patient is crying, laughing, and the patient says, no, it's not actually, they are not my emotions. They are actually being made by somebody else. And of course, motor actions, they say that, these particular actions are actually not mine. They are actually being imposed on me. Thought. Now, all these delusions of control, possession of thought, they are called passivity phenomena. Passivity phenomena because the person or the patient, it becomes a passive, puppet-like person in the hands of a persecutor. Remember that. So passivity phenomena කියලා තමයි අපි මෙව හැම එකටම කියන්නේ. Delusions of possession of thought කියන්නේ something to do with your thoughts, which are usually under your control and cannot be, at all be accessible to another person. So you remember that young girl was saying that her friends actually inserted thoughts into her brain, and that's some of the friends took out her thoughts. She also believed that her father was inserting sexual thoughts into her brain. So that's thought insertion. If they took out your thoughts by some mechanism, it's thought withdrawal. Usually these patients will explain to you that a particular method by which they believe that their thoughts or emotions are being controlled. Thought broadcasting is a different thing. So when you say thought broadcasting, you kind of, mistake it for a perceptual disturbance, isn't it? That thought broadcasting might be hearing your own thoughts. So make sure you don't actually mistake thought echo for thought broadcasting. Thought echo, we will discuss in the net. Thought echo is where you hear your thoughts spoken aloud. Thought broadcasting is where you believe that your thoughts are known to other people. So usually people know things when they are broadcasted, no, right? So remember it like that. If your thoughts are being known to other people, then of course you say the person has thought broadcasting. Okay. So there are 3 or 2 questions. I will answer those and I will stop there. And after that, I will arrange with Janidu or your Devanmini to arrange another time for the rest of the lecture. Okay, so there is one question whether a person is aware, having schizophrenia is aware whether he has the disorder. Now, this is what we call in mental state examination insight. Insight is whether you are actually aware of having a mental illness. Insight usually has 4 components. Whether the patient has noticed some changes in himself, whether he knows that those changes have been, noticed by other people, whether it is due to a mental illness, whether these changes, and whether it is, whether he needs to take treatment. Usually patients don't have full insight. Even us, we don't have full insight into our difficulties and deficiencies. No, you can understand that, right? Sometimes somebody else needs to, point it out to us. So just imagine somebody who is mentally ill, they usually, so insight is a degree. And with schizophrenia, it's very difficult. Usually somebody with depression will have better insight because they know that, I am feeling sad all the time. I think I need some help. Whereas a person with schizophrenia would believe that actually somebody is trying to harm him, somebody is plotting against him, somebody is trying to take over his personal control over thoughts and actions. Therefore, insight is usually very poor in the very beginning. After a lot of patient education and treatment, insight can be improved. Towards the latter part of the illness, of course, patients can sometimes understand when abnormal phenomena are happening to them, and most often they come and say the symptoms have recurred and they need treatment. Okay. Delusions of preference also sound the same as delusional perception. Yes, you are very correct, because I also get sometimes confused by these 2 meanings. Okay, now delusional perception is always there should be a perception, usually like a normal perception. මොකක් හරි එකක් තියෙන්න ඕනේ, දකින දෙයක් හරි, ඇහෙන දෙයක් හරි, දැනෙන දෙයක් හරි, smell එකක් හරි, මොකක් හරි. But delusions of reference is something else happening around you which has no relationship to you whatsoever, right? So maybe a birthmark is on you, so then it is yours, no, it has some meaning or connection to you, In delusions of reference, it actually doesn't have, usually it's something very innocent and something completely unrelated to you. So that is what the thing, actually, to tell you the truth. I also find it sometimes difficult to explain this difference. The best way to remember is delusions of reference very often take the form of, people talking about you. So usually they will not perceive it as, they would not hear it. They would think, these people must be talking about me, right? So it's not like they are actually hearing it. Or that, in the TV, the message must be about me. It is, to give me a message for me to be very careful because my persecutors are coming. Okay, I hope I answered these 2 questions. Okay, any more questions, please? I think a few minutes more to your next lecture, only 2 minutes more. So I think I will stop there. Janidu and Devanmini, I will contact you regarding another time. Thank you very much.
Thank you, madam.
Thank you.